Welcome, everyone. Thank you for joining us tonight. We're going to stand by a few minutes to allow everyone to join, and we'll begin shortly. All right. Good evening, everyone, and thank you for joining us for our Men's Health webinar. My name is Abraham, and I'll be the moderator for tonight's webinar. We'll start with a few housekeeping items, and then I'll introduce our speaker. So first, your attendance tonight is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by me and our speaker. If you do wish to ask a question, please type it in the chat box at the lower part of your screen, and we'll be sure to answer them during the presentation. The webinar tonight could last for approximately 1 hour and will be presented by Dr. Sundaram of Urology, Austin. Dr. Varun Sundaram recently moved to Central Texas after practicing as a board-certified urologist in Gresham, Oregon. He completed his undergraduate studies and medical degree at Washington University in St. Louis. He subsequently completed his general surgery internship and urology residency at the University of Texas Southwestern Medical Center. Dr. Sundaram practices in all areas of male and female urology, with special areas of interest in BPH surgery, vasectomies, prostate cancer, low testosterone, erectile dysfunction, and kidney stone treatment. We have a lot of great content to cover tonight. So Dr. Sundaram, I'm going to turn it over to you to get us started.
All right, thanks, Abraham. We're going to briefly go over some basic points on prostate cancer, the anatomy, some epidemiology, how we diagnose prostate cancer. We'll talk a little bit about treatment options and then focus in about radiation and the use of SpaceOAR hydrogel to help prevent complications from radiation. So the prostate is a walnut-sized organ. It sits between the bladder and the urethra, and it's right on top of the rectum. So there are lots of very important organs here, obviously the bladder, the rectum, and the urethra, but also the nerves running to the penis and the penile bulb. And so all of these things are very close to the prostate, and so when you perform radiation or surgery, there are considerations that must be given to minimize side effects to the adjacent organs. Prostate cancer is very common. About 1 in 9 men will be diagnosed with prostate cancer during their lifetime. It's the second leading cause of death behind lung cancer in American men. In 2018 alone, there were 164,000 new cases of prostate cancer and around 30,000 deaths that year. While this is scary and very common, the important thing to realize is that the 5-year survival rate for localized prostate cancer is over 99%. When you look at all stages combined, the 5 and 10-year life expectancy is over 99%. So it is a very treatable cancer. That is the important takeaway from this slide. How do we diagnose prostate cancer? Well, it's a combination of screening with blood tests like PSA, digital rectal exam, feeling for the prostate with one's finger, and a careful history and physical. Sometimes it comes up with symptoms, but with PSA screening, we hope to catch it sooner than that. A prostate biopsy is the only true way to confirm the existence of prostate cancer. But before we do a prostate biopsy, we can do an MRI to help identify if there are any lesions that need to be targeted. There are a couple ways of doing a biopsy. There's the transperineal approach and the transrectal approach. The important thing with prostate cancer is determining the grade and stage. Grade says how aggressive is this type of prostate cancer, and we use Gleason score or grade group to delineate that. And stage tells us, has it spread, or how locally advanced the prostate cancer is. Is it involving the seminal vesicles or the bladder, or is it spread to the lymph nodes and bone? Other factors such as how rapidly the PSA is rising, genomic testing, the amount of tumor involved are important, but less prognostic than grading and staging. The 3 pillars of treatment include radiation therapy, surgery, and active surveillance. Radiation has a variety of forms. We'll talk about those in a bit, as does surgery. There are many ways to remove a prostate, and there's no one best way aside from what your provider is familiar with. The most common form of prostatectomy nowadays is a robotic transabdominal prostatectomy. Active surveillance involves keeping an eye on the prostate cancer by following the PSA, MRIs, and repeating biopsies as needed to ensure that the prostate cancer isn't becoming more aggressive or changing. There are risks and side effects to any form of treatment. The 3 areas that can be affected are the bowel function, urinary function, and sexual function. Now I'd like to talk a little bit about radiation specifically. Using high energy X-rays, the radiation is focused on the prostate to kill the cancer cells and kill the prostate cells. The surrounding tissue does get some exposure to radiation in doing this, despite the advances in radiation technology. This can result in bowel dysfunction, such as diarrhea, blood in the stool, and rectal leakage. It can also result in urinary dysfunction, the need to urinate more often, having a burning sensation when you urinate, having blood in the urine, or even urge urinary incontinence. There are multiple types of radiation. There's external beam radiotherapy, the old-fashioned CRT, and then newer IMRT, IGRT, and SBRT. Proton therapy is another form of radiation. However, it's important to note that there have been no studies showing an improvement with proton therapy. And there's an AUA guideline stating that proton therapy should not be used in prostate cancer unless you're part of a clinical trial. Because since there have been no studies showing its benefit, There are some thoughts that it could actually be worse than IMRT or IGRT or SBRT. Internal radiotherapy with brachytherapy, low dose or high dose implants can be done as well. Here we see why the surrounding organs are affected by radiation. This is two views of a heat map showing the rectum, the bladder, and the penile bulb sitting very close to the prostate. The red area is the kill zone. This is where the radiation toxicity is high enough to kill the prostate and prostate cancer cells. The surrounding green zone gets a moderate dose and the blue zone a smaller dose. But you see the bladder and the penile bulb, as well as the urethra, are in this area and highly affected by the radiation. To avoid this, Boston Scientific has developed a SpaceOAR gel. In a retrospective analysis of this study, it significantly reduced gastrointestinal side effects as well as genitourinary side effects. We saw the picture of why radiation is sometimes unavoidable. By placing a SpaceOAR hydrogel between the prostate and the rectum, you actually increase the distance, and therefore now the side effect area is hitting just the SpaceOAR gel and not the rectum, and it limits the rectal dose significantly. This decreases bleeding, frequency, urgency, and rectal pain. It can significantly impact the patient's quality of life. The SpaceOAR hydrogel is a temporary gel. It's predominantly water, and it's inserted via an outpatient procedure that can be done under local anesthetic. After about 6 months, the SpaceOAR hydrogel is completely reabsorbed by the body, and there's no evidence it was ever there. It's synthetic, biocompatible, and non-toxic material, and it's mostly made out of polyethylene glycol, which is used in many medical products. Patients who do not receive SpaceOAR were 8 times more likely to have a worse bowel, urinary, and sexual quality of life when compared to patients who did have SpaceOAR gel placed. And this is 3 years after radiation. After the procedure, patients go home and they usually restart their normal activities. We ask them to take it easy for a day or so, but patients after the procedure are back up and at it. What does SpaceOAR do? It creates more space for fewer complications and a better quality of life. There are 75 plus peer-reviewed publications about SpaceOAR and its safety, and there are over 50,000 patients treated worldwide. It's covered by Medicare and the majority of insurances. I'd like to just play a brief patient testimonial.
I was diagnosed with prostate cancer. The level of cancer required medical intervention.
When you're trying to radiate the prostate with radiotherapy, you always have to add in a margin. With SpaceOAR, it allows us to treat the prostate without compromising at that border between the prostate and the rectum, because that border isn't there anymore. There's a big space.
By increasing that physical space and decreasing that radiation dose, it really preserves a man's quality of life.
Having a space there between the prostate and the rectum reduces a lot of that worry.
The SpaceOAR treatment is not a process or procedure that needs to be feared in any way.
I strongly encourage all of my patients who are having radiation to have a spacer placed before treatment.
My greatest hope that it would be available to all persons everywhere.
Okay. If you have any questions specifically regarding prostate cancer or screening or even treatment and SpaceOAR placement, you can call the number listed on the screen to schedule an appointment with me at Jollyville or Westlake. And at this point, I'd like to open up for questions. Abraham, do we have any questions?
Yes, we do have some questions. All right. First question here. Is prostate cancer hereditary?
It can be. There are